Okay, so good morning, ma'am. I am Catherine Joyce Ruiz, and today I'm going to perform an actual nurse checklist. So for the preparation, I have here all the equipment ready, different kinds of scissor, but first for the mother. We have here adult diaper and the patient's gown. And also we have here sterile instruments for DR, the bandage scissor to cut the umbilical cord, the Mayo scissor to cut the perineum, the Kelly clamp, and also the cord clip. Kelly clamp used to clamp the cord towards the placenta, and cord clip to clip the umbilical cord, needle holder to hold the needle while doing sutures, and one tissue forceps to handle dense tissues in the skin, 15 pieces of 4x4 or sponge, assuming that these are 15 pieces, that is used to remove excess blood on the perineum. And also we have here kidney basin where we will be putting the placenta, and sutures. These are not the actual sutures, but yes, you need sutures, especially when episiotomy is needed. So the commonly used sutures is round-bodied, but still based on the preference of the physician. Also, we need one piece of 5 cc syringe with lidocaine for local anesthesia and Mayo table. So assuming that this is separated from the delivery table, okay, so we need Mayo table because it is where we will be putting all the instruments. And also we need one pail, okay, this under here, to catch the fluids and blood, and also the solid sponge. And next is the PPE, okay, PPE and sterile gloves, so this should be sterile. Okay, and next is drapes. Okay, we need 3 drapes, one for the leggings, one for top sheet and bottom sheet. But this time I don't have enough material, so yeah, I'll just mention them. So for the rationale, certain procedures requires a specialized set of instruments for organization and efficiency. So next is I'm going to assess the uterine fundus by palpating the contraction. Okay, make sure we have clean hands and rub them. Okay, so we're doing this to determine the frequency, duration, interval, and intensity. Okay, so for the rationale, we also do this to determine whether the contraction pattern is really the true labor, and also to identify any kinds of abnormalities of the contractions that may possibly jeopardize the health of the mother and the fetus. So to enumerate the frequency, duration, intensity, and interval. Frequency is the period from the beginning of one contraction up to the beginning of the next contraction. And the duration is the length of one contraction, meaning it starts from the beginning and end of only one contraction. And for the interval, it is the in between 2 contractions, so meaning it starts from the end of one contraction and ends in the beginning of the next contraction. So it is typically assessed to because most of the fetal exchange of oxygen, nutrients, and waste products happens at that time. And lastly, for the intensity, it is based on the strength of the contractions. It can be described as mild, just like the tip of our nose, moderate, just like our chin, and strong, just like our forehead. So that's all. And next is we're going to monitor the progress of labor using the pantograph. Okay, so we have here the time, and also after assessing the yun. Okay, so for the rationale, this collects the important observation to assess the progress of labor using this graph. And also, we are doing this to check for any abnormalities, and so that we can know when we need to call for referral. So next is we're going to wash our hands and wear PPE and sterile gloves, maintaining the sterility of the gloves. So assuming that this is sterile, Yeah, I am not going to wear anymore the PP because it will take me much time. So this, for the rationale, this protects me from any possible transmission and prevents any transmission of microorganisms. So next is we're going to apply lubricant to examine the vagina of the mother. So we're applying lubricants to our index and middle finger. Okay, so this is, and also the rest of the finger should be kept away from the vagina of the mother to prevent, to avoid passing the microorganism to the vagina. Okay, so we're doing this to, we're using lubricants to reduce, of course, the pain during vaginal examination. And for the vaginal examination, we are doing that to determine the cervical dilation, defacement, fetal position, presentation station, and also whether the membrane is ruptured. So next, we're going to do a perineum prep. Okay, so aseptically using 6 sponges soaked with betadine, 10% betadine solution. Okay, so we're going to start in a zigzag motion from mons pubis going up to the lower of abdomen just above the symphysis pubis. Okay, zigzag motion. Okay, put it in the pail. Always remember that don't use the used sponge to the clean area. Okay, next is we're going to do again zigzag motion on the inner thigh of the mother, inner thigh of the mother from labia majora to about halfway of between the hip and knee. Yeah. Then use another. Okay, make sure that these are soaked in betadine solution. Zigzag motion. Okay. Okay, next is we're going to do one single stroke. Okay, on one side of the perineum, starting from the clitoris over labia minora, perineum, and anus. One stroke. And then another from the other side. Okay, clitoris, labia minora, and yun, tas anus. Tas lastly is a single stroke from in the middle of the clitoris over the vulva and perineum. Middle shrink. Okay, so we're doing this to prevent contamination and cross-contamination of an area which is already clean. That's why we don't let the used sponge touch the clean area. Next is we're going to apply sterile drapes. Make sure to observe sterility of the field. Okay. Okay. So apply sterile drapes. And also this top sheet. Okay, so we're doing this to help us trap the fluids, which will also help us clean the area easily later. And also it reduces cross-contamination or contact of the stop and patient into the blood and fluid. So next up, we're going to give birth the head of the fetus. Okay, so the head is now going. So after injecting the oxytocin, so this time there is a possibility that we need episiotomy. Okay, so it should be done, or it should be performed when the head is already well crowned. Okay, so assuming that we will be doing that. Okay, so the angle of episiotomy will be discussed later. Okay, so we're doing this to minimize the blood loss. There. And next is after that, we're going to control the exit of the head so that it will not pop out, and it will uh, gradually be born. Okay, so to do that, we're going to perform Ritgen maneuver by applying pressure on the perineum with one hand and one applying counter pressure on the fetal head once the vaginal orifice encircles the fetal head. Okay. And also, for additional rationale, it also minimizes the trauma of the maternal tissues. Okay, okay, alalay. Next is, after the head is already born, we're now going to remove the blood and secretions by wiping the infant head. Yeah, so we wipe the infant's head and remove the secretion using the bulb of the syringe. Okay, so we're doing this to prevent infant from aspiration during the first breath. So next is we're going to assess if there is a cord that surrounds the neck of the baby. Okay, using our fingers. If it is loose, we can just flip it over the head. But if it is tight, we can use two clamps and cut in between. And so we are doing that to prevent the stretching or tearing of the cord. So after that, okay, so the head is now already out. We're doing external rotation. External rotation. Okay, and apply gentle traction on the fetal head on the direction of the ano. We're going to apply gentle traction on the fetal head in the direction of the mother's perineum. Okay, we're doing that so that the shoulder rotate internally and flip under the symphysis pubis. Okay, after that, we're now going to lift the head towards the mother's symphysis pubis. Okay, we're doing that to minimize trauma on the maternal tissue. Then after that, the shoulder will be born. And now, we're ready to pull the rest of the body. Okay, and then say, baby out, and place it over the mother's abdomen. Yan. Place it over the mother's abdomen. Okay, so for the rationale, we make sure to call the baby out clearly and loud enough to be heard by the workers surrounding you. So to provide information about the fetal status. Yeah. And also maintain the infant in a slightly hand-dependent position. Okay. As we suction the excess fluids and secretions. Okay, so again, it is only done if needed, if the baby is not crying. Yeah. So after that, we're now ready to give birth of the placenta. So in doing that, we're now assessing the separation of the placenta. Okay, so in doing that, one to be considered is the firmness of contracting of the uterus. Okay, so next is we're also assessing the change of the uterus from discoid to globular ovoid shape as the placenta moves into the lower segment. And also the sudden gush of dark blood from and also prevent lengthening of the umbilical cord as the placenta draws closer to the borders. Okay, so for the rationale, of course, the goal of the third stage labor is the separation and expulsion of the placenta. It should be achieved in an easiest and safest manner. And next is we're going to, okay, so I'm going to apply what I have seen on the video. So in there, they use this clamp. Okay, so in doing that, we're going to control the traction of the umbilical cord. Okay, first, gently massage the uterus, okay, when sign of separation is already noted. Then, apply counter pressure on the uterus beneath the pubic bone, okay, using our one hand, and until the placenta delivers. Okay, so according to the video, they clamp the cord and then gently pull it. Don't force it. Massage the abdomen. Okay, and then move it. And then pull it again until you see the placenta. Okay, when you see the placenta, hold the placenta and then massage the perineum line. Then gently pull it. Then pull it and then put it in the kidney basin. Okay, so for the rationale, we're going to facilitate the delivery of the placenta and amniotic membranes, and also excess traction of the cord may cause it to break, so we have to do it in a very gentle manner, careful manner. And also, next is we're going to inspect the placenta for completeness. So according to the video, the side should be complete. There are no torn out area. And yeah, so for the rationale of that is we have to be certain if it is intact and part of it was not retained, to preventing the uterus from fully contracting and lead to hemorrhage and infection. So next is we're going to assist the episciorrhapias. Yeah, so if needed, just like what I have mentioned before, there are two types of episiotomy. Okay, it can be either midline cut, or median cut, and mediolateral cut. And for the incision, there are also two types of episiotomy incisions: median or midline incision, which is done vertically towards the anus, but the pros of that is it is very easy to repair, but it has a higher risk for extending into the anal area. While the next type, which is the mediolateral incision, it is done in an angle, slant angle, and it assures the best protection from the extended tear that may affect the anal area. But it is more painful and more difficult to repair. Okay, so for the rationale, routine episiotomies are no longer recommended because it can affect to the pain that it produces and the discomfort resulting to the episiotomies can also interfere the mother and infant interaction, like breastfeeding, and also the establishment of sexual relationship with partner, and even emotional recovery after birth. And also, but still, if it is needed, it can still be done to prevent laceration and unnecessary tear of perineum. So next is we're going to remove the drapes. So this will be taken care of the assist nurse. Okay. Again, we're now going to remove the drapes. Okay. Discard it, remove, and then do pedicure using sterile water. Sterile water, care. And next, we're going to give her diaper, adult diaper. Okay, so just be careful especially when it has incisions. Okay, so this diaper provide comfort and easy assessment of the amount of lochia. Next is we're going to check the DR instruments if they are make sure that they are clean and soaked as per agency policy. This is done to check if they are complete, if the instrument used are complete, and also for sterilization of instrument ready for the next deliveries. And also instruments are usually pre-soaked, should be pre-soaked and pre-rinsed to prevent drying of blood and tissue. So next is disinfect delivery room. Okay, so we're going to disinfect this. Okay, so the mother is already out na dyan. So assuming that the mother is already out, we're going to disinfect this. Yan. And after disinfecting, okay, so for the rationale, disinfecting the delivery room and table prevents cross-contamination and spread of microorganisms. So lastly, okay, we also disinfect our hands, clean our hands. Okay, make sure to discard anything that is needed to be discarded in a proper area. So lastly is we're going to record the procedure done, assessment, and data of the client. So for the rationale of that, documentation provides an accurate nursing skills, and also it supports multidisciplinary team to deliver quality care. So that's all po. It completes the checklist for actual nursing. So that's it po.